Chocolate for
Chocolate, exactly.
frustration. Welcome back to Endoscopy Essentials, Gastroplasty. Barham, welcome.
Thank you.
Thanks so much for your beautiful lecture last time. Now you finished, you're very proud, but what happens to the patient?
Yes. So now we're going to talk about recovery, the expectations, and what to do. Most of these patients, by the way, are going home. So, but you cannot
same day.
Same day. But you cannot just assume that it's going to be the recovery of a colonoscopy. You're going to have to do some preparatory work to have them go home, and that preparatory work starts before the procedure. So you need to anticipate that the stomach is going to be swollen beyond the restriction of the procedure itself. There's a lot of swelling that makes that lumen even narrower than it will end up being in a week, but you have to take that transition period in mind. So what we do is we want to maximize three things: antiemetics, non-narcotic pain control, and prophylaxis for bleeding after the procedure. So these are the three principles that you need to focus on. So for the accommodative symptoms and prophylactic post-operative recovery, we utilize multiple agents. We utilize Decadron, which is a steroid pathway at 8 milligrams. We utilize ondansetron or Zofran, which is the second pathway. But we utilize now a third pathway, so to saturate all receptors, is a medication called aprititant or Amend that I think works on the NF-kappa B pathways, which is a new, novel, strong pathways in preventing nausea.
Which means all three.
All three.
So
And
it's
all
not a stepwise, and we see how symptomatic.
and all three prophylactic, not reactive. Once they start into the cycle of nausea, it's not going to end well.
Yeah.
So all these are the Amend or the aprititant is administered the night before or the morning of the procedure. Don't do it the morning off if you're going to pull the pill form because you're going to suction it out. Do it the day before if you're going to use the pill form. What I use is the IV form of that medication. It's called FOS aprititant. It comes at 150 milligrams, and I give it IV the morning of the procedure. Then I give the Decadron during the procedure, and then I give the Zofran towards the end of the procedure. So they're all hitting at different time point to prevent that.
Which is a very differentiated approach.
Yeah.
So it's
Yeah.
okay, good.
So nausea is the big one. Second one is pain, and pain is to be expected. You're violating that serosa many times during the procedure. So the stomach is going to be inflamed, and there's going to be referred pain coming from this. The pain is not miserable. You're not gonna see somebody walking out shouting, but it's going to be a dull ache, just like inflammation in that side of the belly. And for that is we try to maximize non-narcotic pain management. And so I use IV Tylenol or paracetamol if you have that. So that's one important pathway. And then the second important pathway is using an anti-inflammatory drug like Toradol, for example, through intravenously. And these are usually sufficient with a small dose of narcotic to get them to that transition from the intraoperative to recovery. And with that, I utilize Dilaudid as the agent of choice because its half-life is in the hours, not like fentanyl, which is few minutes. And that now with the narcotic carrying them until they go home, and the Tylenol, which we gave in the morning off, is hitting at the same time. And then the Toradol, bridging both of them, most of the pain is very well managed, and most people leave with no issues.
How is the physical abdomination of the abdomen?
Very soft.
It's always soft. So if it's tense, then
if it's tense, you need to evacuate air from the belly. So that's something. But it's very unlikely that you needed to do this. If you do a CT scan, you will likely see some peritoneal air for sure, but it's very likely that it's of a volume that you need to decompress. So
not like poem.
It's not like poem.
Okay.
in the event that happens, a decompression needle is sufficient to do that. But I found it very rare.
Probably check at the end of the.
You check at the end of the procedure before you wake the patient up. Yeah. Absolutely. Most of the time, the stomach is soft. They describe this dull pain sensation. You push on it, they could tell you that, oh, you're pushing in that area, but it's not diffuse peritoneal type of pain that they experience. Okay. And most of the time, if you did the anti-nausea and you did the pain medication, it's pretty smooth sailing. The third one, which is the third pillar, is prophylaxis for bleeding. These are sutures that are going to start healing and incorporating with each other. So what I would do is PPI prophylaxis. Twice daily PPI for the first 3 months, then I will taper it to off. We don't need PPI forever. It's just the period after the procedure for the healing. And then I use a medication like sucralfate in order to kind of cover that area and enhance the protection and the healing. And usually between these pillars, nausea, pain, and prophylaxis for bleeding, recovery is pretty smooth, and I tell the patient the rules of 3. Tomorrow morning is going to be the peak of it, so that's why tonight, focus on clear liquids. We gave you 2 liters of IV fluid during the procedure. Your job is to keep a glass of water with ice, or even better, get some Gatorade mixed with water. And as you see fit, I'm just trying to get them used to it. Every 15 to 20 minutes, take a sip. Don't worry about anything else. Then tomorrow, you'll see that your pain and nausea are improved by 50%. That's when we go to a full liquid diet. You start putting protein shakes in there. Then after tomorrow, the pain should be almost gone. Then you start advancing your diet.
If not, call us.
What's that?
If not,
call us. That's right. And then you should advance your diet further. And usually it's a transition period where protein shakes for about 3 weeks to allow the healing without the pressure of the food. Then you go soft diet for 1 week after, then healthy regular diet after that.
Do you do counseling after 3 months or 6 weeks? Or?
Yeah, that's where we said we differed from the standard. We give solutions, then we enable the patient. Most of our counseling comes after the procedure. So because now the patient in the first month loses 30 pounds or 20 pounds, and it's like, wow. This is enabling. I like that effect. I could take control. I want to know what I could do to maintain it. So now they're asking you the questions. You're not asking them the questions. So yes, so now is the heavy lifting of healthy living counseling, not diet and exercise, not behavioral, it's healthy living counseling. And what we do is a series of 12 steps. So they come, and you don't have to do it as a physician. You're nurse practitioners, we at Mayo, when I was at Mayo, we had healthcare coaches who are trained in motivational interviewing and listening to the patient needs, who really help guide them through that journey. But it's a series of 12 steps that includes nutrition counseling, what's a healthy diet, what's portion control, what do you have on your plate, and how do you adjust your plate based on your lifestyle. Then talking about physical activities, and there's 3 main components of physical activity: strength training, aerobics to get your heart rate up, and the third one, which people ignore, is balance. So Pilates and the yogas of the world is very important concept of that. So balance, strength, and aerobic to get your heart up is the 3 principle of exercise. And exercise does not mean that you need to hit the gym for 2 hours in the morning. You could really do all 3 components, waking up in your room, doing a bunch of push-ups, balance exercises, and just jumping around, and you could get what you need to do as far as exercise. So we try to demystify this concept that you could accommodate a lot of this in your daily life without all the glamour of what people say you need to do, and then we talk, and then the behavioral intervention. A lot of people, food is psychologically ingrained in their lives. We eat for all other reasons other than being hungry. We eat when we're happy. We eat when we're anxious. We eat when we're depressed.
Chocolate for
chocolate, exactly.
Frustration.
So trying to give them through a 12 simple behavioral intervention that we developed with our psychology and behavioral interventionists. But these are nothing that needs a psychologist to sit down with you. There's a picture showing what's the cues that are temptations, how to. Most of it comes from the knowledge that you understand that this is a cue and a temptation, and processing this information that I am being tempted now, and I'm going to resist this, and I'm going to focus on a more health-inducing activity is sufficient to address most of the behavioral intervention you need to do.
And now you have a motivated instead of a frustrated patient before because he failed.
Because they failed and they're enabled now. And now you always, humans are storytellers. We want to tell a story. And we resonate with stories. So now they're telling their story and they're living it. And it becomes a very healthy way to lose weight. We did not do something. We tell them, you're doing most of the work. We just give you the catalyst to do it. And they love that catalyst. They love the fact that now they have a procedure that is not minimally disruptive to everything they do in their life and everything they like to do. They still have their stomach in there, but it enables them to now say, I'm going to take control and I'm going to adopt this, and that. And no, we're not doing marathon runners. We're telling people, live a simple, healthy life. And that message of simplicity resonates with many.
Common sense.
Because a lot of, I get frustrated when I go to congresses and hear multidisciplinary, I was like, does it mean that I need to commit my life to this? Because I have kids to take care of, I have a job to attend to. How would I want to live healthy, even if I want to? Because we make it so mystified. Here it's, no, healthy living is simple. You could adopt healthy living around your life. It's a lifestyle choice rather than it's a forced medical intervention.
You don't have to go to a monastery.
You don't have to go to a monastery. Yeah. That's right.
Okay, good, fantastic.
Yeah.
At the end of this, something very important. What can happen? What are the complications? I think we have to talk about that as well.
Yes.
It's obviously not very complex. It's rather safe, but things can happen.
Things can happen. And that's to any intervention in endoscopy, things can happen. So what could happen, let's say in the acute setting, might be different from what happened in the chronic setting. Let's focus on the acute setting. Most of the serious adverse events will be in the acute setting. Beyond the acute setting, once the healing process happens, it's very little to worry about because you still have your stomach. You don't need to worry about micro or macronutrient deficiencies to the same level that you worry with bariatric surgery, for example. So in the acute setting, what happens is your standard post-operative issues, and the big one here is DVTs and PEs. And to me, is you're dealing with patients at increased risk for this to begin with. Yes. So you need to be cognizant that you put them through a procedure that might increase that risk. So to me, it's I counsel them to ambulate early and often, even if they're not feeling up to it. I go to their significant others or family member and say, your job over the next 2 days is to make sure they're getting out of bed every hour and taking a small walk. And that usually it's a good, simple enough intervention that they all could resonate with, and they start pushing, and that minimizes that risk. In people with higher risks, I give prophylactic medication in order to prevent that risk. But that's a question, is if they have high risk of clotting disorders or family risk, it does not add to the risk of bleeding of the procedure. So I judiciously use it all the time if I need to. The other risk is to worry about is these micro leaks. You never see a big hole with this procedure, but there is an incidence of about probably 1% or so where things go well, but patients come back with tachycardia and they come back with symptoms of peritonitis, and you realize that there's a collection that formed outside of the stomach.
On CT or
on CT scan or whatever. And usually, the vast majority of these, you do not need to rush to call your surgeon and take the patient who already had a very altered stomach because of the procedure, go operate it on, because that's where I've seen the disasters happening. That's when we become really good interventionalists, saying, okay, we could deal with this. We need to do what's right for the patient. So the principle goes is if you see a collection that looks infected, drain it. So interventional radiology drain with antibiotics is your first step to do that. Then you look endoscopically, oftentimes you won't see a hole. So most of the time, that's the interventional drain, and the antibiotic is sufficient to resolve these tiny microperforations that we talked about.
Gastric tube?
What's up?
Gastric tube?
Gastric tube is a good idea, especially that because of now the leak, there's going to be more inflammation and they start vomiting and stressing the other sutures. So yes, decompression, drainage, and antibiotic is 99% sufficient to deal with these. I personally, out of thousands of cases, I haven't needed to send somebody to surgery, although I had a handful of patients who did develop these leaks, but they were managed conservatively.
Any endoscopic options, or is everything swollen and you don't have any chance? Should you see something?
Should you see something, your best option is do not disrupt the rest of the sutures. Just don't, because you're going to create a bigger problem. So if you see something, and I think I remember one case where we saw something, and we saw something based on contrast injection under fluoroscopy. We saw the track. I used an ERCP occlusion balloon and an angled 035 wire, maneuvered the wire through the crevices under fluoroscopy to that leak, and put a pigtail stent. And that patient did fantastic.
Okay.
I did not disrupt anything. I did not go start cutting sutures. I did not put stents. I did not go suturing over suturing. I just figure out where it's coming.
Fancy clips or?
Fancy clips. Figured where it's coming, had a wire in there, coiled it in there, and snuck a pigtail catheters, and the patient did fantastic. So again, same principles that we use for everything is do what's needed. Don't do what's not needed in these things, because practically speaking, in the middle of all these application, to find something that you could clip efficiently or suture efficiently is very, very rare.
And if you look too aggressively, you might increase the hole.
You might increase the hole or create a newer problem that you did not want to create.
But then that also tells us that you did this procedure in the fluoroscopy room? With the guide wire and...
the complication management? Yes, absolutely.
Yeah. Okay.
If I'm going to anything interventional, I never do any procedure without fluoroscopy.
Okay.
Because it's endoscopy has its limitation, and as we know,
especially with leakages.
Especially with leakages,
okay.
Absolutely. Yeah.
Good.
So we talk about thrombus, we talk about leaks, bleeding is the third one. The good thing about bleeding is most of it you could see in the procedure and you cinch as you do. I haven't personally had it. I heard about few cases where bleeding was coming from outside the stomach. Again, I haven't heard that it required surgery or not, but it's very rare that it comes from outside the stomach, but that's something to keep an eye on. I don't have personal experience with this because it never happened with me, but a hematoma that happens outside of the stomach is possible. That could be a source of bleeding. Most of the bleeding is managed in the procedure. The other bleeding category is those who use APC. They realize that they might have delayed bleeding because the APC have created a small ulcer and now that ulcer is bleeding. So in that setting, you could keep PPI and sucralfate should be sufficient to prevent that. But if it happens, most of this bleeding that's induced by ulcer formation could be managed endoscopically. That's where your traditional tools, clipping and burning and stuff, come in handy. But acute bleeding because of a vessel, intraoperative management. During the ESG, you're cinching. Outside hematomas could happen. They're rare. I haven't seen them to the level that they're clinically significant, but I keep a vigilance that they could happen. Ulcer-induced bleeding, mostly because of APC usage, could be managed with traditional hemostatic tools.
Okay, I mean, and I still could visit the patient with a surgeon just in case.
Absolutely. But I try to push not to operate because the operation is more. It's not one of these situations. Surgeon is going to solve your problem, and you have to do what's right for the patient. It's a dialogue, of course, between you and your surgical colleagues, but you have to also advocate for the best outcomes. And to me, it's an operated on stomach that you need to use the minimal invasive approach to manage that complication.
Right. Yeah. So at the end of this, you have this complication overview slide. Maybe we have a look at that.
Yeah, absolutely. So that slide is actually one of my fellows or collaborators put this together. And this is how the idea is to put the adverse events profile, but also to highlight the value proposition of endoscopy compared to medications. No free rides. Everything has complication, everything has risks. But we are in an era where endoscopy has the same value, whether it's safety or efficiency as medication. Medication has their unique value proposition, but also endoscopy has their unique value proposition in this perspective. So if you look,
Remember our first podcast.
That's right.
You had these overlapping circles.
That's right.
Circles.
Exactly.
So
here we are now putting numbers to these. And you can see here's the ESG. If you pull the data, it's about 16,000 procedures in the published literature. And you could see here's the total body weight loss in the neighborhood of 17% and over the 3 years horizon. Medications, the older versions, they were not achieving this kind of weight loss. It's in the 3 to 4%. Then they became better. They start pushing 11 to 15%. And the newer ones are really pushing that envelope to 15 to 20%. But it's in the neighborhood of what we could achieve in that time horizon. Of course, with this degree of weight loss, you're going to have metabolic improvement. Whether medication, endoscopy, surgery, with that degree of weight loss, metabolism improves across the board. And you could see medications have compliance issues. There is adverse events like pancreatitis and GI side effects. Endoscopy has more unique acute side effects. So SAE rates that we talked about is about 1.25%. But let's put this in context. A colonoscopy with polypectomy has a 0.8% risk of adverse events. So we're talking 1.25%, not too far from that. But the unique value proposition is compliance is maximized. You cannot discontinue an ESG. Now you have a procedure that the patient does not need to remember to take an injectable that's going to last them 3 years. And that is its unique value proposition with a safety profile equivalent to the medication and with an efficacy equivalent to the medication. So let the patient choose what they gravitate to. And that's why this is important to highlight this in this context, because people think it's a pyramid. Use this, then go to this, then go to this. And to me, I disagree with the pyramid. We have a big burden of disease. We create pillars that have unique value propositions to patients and healthcare systems.
Right. And I think, again, what we discussed very briefly in the first podcast, how the interplay of drugs and ESG will be, we will see.
Absolutely.
With further studies.
Absolutely. And by the way, carrying that conversation of unique value proposition, there's been multiple cost effectiveness analysis. This is published in JAMA, and there's another one published in Gut that highlights that this endoscopic approach could be very favorable and cost effective to healthcare systems and to patients. So I think we're still at the tip of the iceberg of what's coming next with these approaches. And that's another teaser, is there's a lot coming, but we have to build pathways where the common theme is we believe that the answer to the metabolic diseases lies in the gut. Once we realize the gut is an important regulator, then the therapeutic options becomes endless, and we could explore many things to do in there.
What a nice conclusion.
That's right.
I'm deeply grateful. Thanks so much.
Pleasure.
Thanks for watching. Fascinating series, but there is more to come, Barham, right?
Absolutely.
Yeah. Thank you.
Pleasure.